So you got that detail, but I just want to give Ardith enough time here. And so today's speaker, going over the 2021 CPT updates regarding physicians, is our manager of product content, and her name is Ardith Campbell. Ardith.
All right, well, thanks, Dusty. Yeah, so here's my name and my credentials and our basic disclaimer statement that this is current as it can be. I did check the AMA website just a short time ago, so there have not been any new codes sprung upon us. But as you know, things are changing at a very quick pace these days. So we're going to go have an overview of the CPT, a few HCPCS code changes, but not too many. The files were published pretty late in the day for us to get all of the content into the slides. So we'll just kind of have a chapter review of the CPT code changes and take a look at the Category 3 code changes. And here's kind of an overall look at the slides. And these totals do not include codes that were added, deleted, or revised during the year in 2020. Now, when you're taking a look at the Appendix B in your CPT book, they have many more codes than we have listed, and that's because they count all of the codes that are appearing for the first time in the CPT code book. So as you can see, there aren't a ton of additions or deletions or revisions, but it's the content of those that is interesting. So we're going to take a look at some of the CPT code changes, and we're not going to spend a ton of time here because we do have another webinar next Thursday, same bat time, same bat channel, to go over the E&M changes, and we'll go more in depth on those. There are revisions to the code descriptions, there's revisions to medical decision making, new guidelines for using time for the codes. The time range is provided within the code descriptor itself, so there is no need for that mid-range to bump up to the next level. Now they are taking, and these are only for the office outpatient visits, and they are taking a look at the other office E&M visits, such as, in the SNF and domiciliary. They're thinking about the emergency department visits, but they're not decided on that, and that has to do to the intensity of the services that are provided in the emergency department. And we've got new definitions in the medical decision making, and also new prolonged service codes. So now one of the updates to the time is that you use the date of service on the time, and that is really building up on the movement over the last several years by Medicare to better recognize the work involved in the non-face-to-face services, like your care coordination. And so some of those are going to only apply when that code selection is based on time and not your medical decision making. And so the time may be the only component used for your code selection, except for your low-level office visit. And the counseling and coordination of care does not have to be 50% of the time or more. So that is changing. So you'll see that the time is stated within the descriptor. So there's no need to have to hit like 16 minutes to bump up to the next code. Like similar to using the initial hour of your infusion, where you have to have at least 31 minutes to report the hour and then 91 minutes to report the additional. There's no need for that. And so with this only being the update to the office level visits, it's not going to impact how you code and the code selection for the other ranges of E&M visits. So you need to be careful when you're selecting the codes. So you're not quite ready to get rid of the 95 and 97 guidelines yet, but we're on the way. So the total time on the date of the encounter can be used, and that the time for those services is the total time on the date of the encounter. So it includes both the face-to-face and the non-face-to-face time personally spent by the physician, or if it's the, a nurse practitioner, physician assistant on the date of encounter, and it includes those time, that activity that requires the physician, but not those performed by your clinical staff. So it would not be including your time spent by your medical assistants, or your nurse or the lab technician or whatever. And this information has been added to the E&M guidelines. You do have access to it in printed form. Now, what is included as what is included within the time. So this list is also in the E&M guidelines. And now it's not stated that you have to have a specific start and stop time, and because the times can be cumulative. And, so you could see the patient at 10 a.m., but provide counseling and education to the family or caregiver at a later time. It could be that in the morning you're reading through your chart notes for everybody coming in just to kind of get up to speed on who you're seeing. That time counts. So, preparing to see the patient where you're kind of reviewing the chest or the tests, obtaining or reviewing separately obtained history, performing a medically appropriate examination and or evaluation, that is optional. So if you don't need to, if there's no need to get the stethoscope out to listen to the heart and lungs, you don't need to. But it does include, any of the counseling and education for the patient or caregiver. And then for the care coordination, it's if you're using the time to do something such as the chronic care management or the transitional care management or some other type of coordinated care, you can count the time in one place but not the other. So it's very important to remember that only count a minute once. And so what this is supposed to do is hopefully cut down on note bloat. So what you're getting is pertinent for that patient, but it's going to be important that the documentation supports what is being done. So that part is not changing. So with this, it means that code 99201 is being deleted, and the suggested replacement is 99202. The only difference within the two codes was the presenting problems usually being self-limited or minor, where on the 99202, it's the little bit higher level. And the AMA said that, they felt that a new patient visit would never be completed in just this amount of time, or with the limited or minor medical decision making, that pretty much if it's a new patient, it's going to be at least a 99202. All right, so here we've got the revised descriptions for the 99202, and I changed the font, or I changed the typeface to red so you can see the differences in the time. So for the 2020, the 99202, it's 20 minutes, typically 20 minutes, where in 2021, if you're counting by time, it's 15 to 29 minutes. So what the AMA did was on the new visits, they go by 15-minute increments. Because they have, with this one, you have your straightforward medical decision making. The nice thing about the codes now is that, like the 99202 and the 99212 will have the same straightforward medical decision making, and so they align. So, and here you can see for the 99203, it starts at 30 minutes to 44 minutes. So they've gone in 15-minute increments for the new patients. And so I'm not going to read through all of these because you'll have the slides and you can review those. And so 60 minutes to 74 minutes of total time. And so the notes for the AMA from the CPT manual state that first service is 75 minutes or longer. See the prolonged services code 99417. And please remember the time on this, 60 to 74 minutes, because it's going to come in handy later. And then for the 99211, here the change really is just in the last sentence. They removed the time, and this is usually the service that's reported by someone who's working incidental to the physician service. And so this could be your nurse, the pharmacist, the medical assistant, and so on. So the changes really are consistent in saying it's the office or other outpatient visit. You know, you have your new and established. And for the established patients, the time increments are in 10-minute increments. And really, using the time is going to may not really be necessary, because the documentation from the chart notes can get you to a higher level office visit without it being that increment of time. All right, so I'm just going to go ahead and go along. And then for the 99215, this one is 40 to 54 minutes, where at 55 minutes, you would start your prolonged services. And what I want to say for there is a big difference between facility reporting and the physician reporting in this instance, because not a lot is going to change for the facilities. Sure, there's the loss of the 99201, but that really shouldn't be occurring anyway. But facilities still to Medicare report the G0463 for their outpatient office visits, and then you use your own internal guidelines according to your resource utilization for code selection. So facilities are not dependent upon the code descriptors as much as for the physician reporting. All right, now for the next spot, there is a new HCPCS code for a complexity adjustment. And yes, that paragraph really is the description of the patient, or of the HCPCS code. It's visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed healthcare services and/or with medical care services that are part of ongoing care related to a patient's single, serious, or complex condition. Add-on code list separately in addition to office outpatient evaluation and management visit, new or established. All right. There, in the physician fee schedule final rule, there seemed to be a lot of confusion as to when this code would be used. And so we're expecting that more information will be forthcoming to help people understand better when they can use this code. But what CMS is saying is that this is to help help providers capture additional reimbursement when they're furnishing services to patients that have on an ongoing basis, so that you can have what they call that result in a comprehensive longitudinal and continuous relationship with the patient, and involves delivery of team-based care that's accessible, coordinated with other practitioners and providers, and integrated with the broader health care landscape. So what And when you get, they did provide a couple of clinical examples. So one of the examples they gave was a 68-year-old patient with congestive heart failure, diabetes, and gout. So you have a lot of things going on with this patient. So you probably see them a little bit more than normal. Some of their care takes a little bit longer, or getting the coordinated care takes a little bit longer. So you have a lot of moving pieces and parts that you have to deal with. And it's to help establish that a long-term relationship with that patient. Now, what it didn't say was that, okay, you are seeing this patient expecting to be able to see them for, the next 5 years, 10 years, but they up and move to a warmer climate. And so you only saw them 6 months. That hasn't been addressed. So I can't answer that question. But what they're saying is it's not restricted to any specialty, but it's going to be for patients that have that complex care, and you're expecting to have kind of a long-term relationship with them. So you would use it for that patient with the congestive heart failure, diabetes, and gout, but you would not use it for anything like if a patient comes in for seasonal allergies. They also had another example of somebody going in for a simple mole removal. Well, that would not be an expectation where you would use this complexity add-on. So, or if you were just referring them for a mole removal, that would not be something that you would use this for. Now, if the patient goes in for a simple mole removal and you find out they have squamous cell carcinoma, or some other type of melanoma, and you might then start to be involved in coordinating chemotherapy, those types of things, and it starts to get more involved in the care, that's when you would use and you are the person, you are the provider that's coordinating that care, then you would be able to use the code. And so they're not expecting that any specific specialty would use this, but they are expecting some specialties more than others to use it. And of course, they didn't state which specialties. So hopefully we have some more information coming out to help decide when we can use this, but it's going to help include more patient education, the expectation and responsibility. So if you use the, like in the diabetes example, where you have the nurse that's doing their, training them on how to give their insulin shots, or their expectations regarding, hey, we want to try to get your weight down a little bit, stop eating 5 chocolate bars a day, those types of things. And have that type of discussion. All right, now remember how I said, remember the times for the 99205 and the 99215. And the when you would start those, so CPT says for the 99215 at minute 75, and for the 99215, it's at minute 55. Well, there is a new prolonged service code, and then some of the revisions have to do with using this code. And this is for reporting when the physician has direct time, and you're coding based on time. And so the nice thing is I've got a little tooltip. So if it's less than 75 minutes, you're not going to report it separately. 75 to 89 minutes, you can do the 99205 and 1 unit of the 99417. And so I have included that here for you. Now, then CMS has to, they were a little bit confused by the times within the code ranges that they'd asked to have put in the code descriptions. And so CMS and CPT are in disagreement about the code usage. And so CMS created a new prolonged services code, the G2212, to also be used with the 99205 and the 99215, but they start from the ending time rather than the beginning time. And so they have a separate reporting table. So it is a little bit different from the AMA. It's different by about 15 minutes. So you would not use the prolonged services code until minute 89 for the 99205 and at 69 for the 99215. And I'm sorry, it's just, I don't know. Sometimes you wonder. Okay, and so what that does though with the prolonged services, there has to be a revision. Some of them it's just kind of rewording, so it's a little more consistent. You know, they put it at the end of the code, but they also have, and remember they have the differences between where it's being provided, whether it's in the outpatient setting, the 99356 is in the inpatient or observation setting, and then we've got the 99415 and 16 that is your clinical staff time. All right, and so we've got a new add-on code for chronic care management, and so this is for each additional 20 minutes of clinical staff time. So it kind of gives you the chance to increase the amount of time that may be spent on some patient for those care management services. So the 99487 and the 99490 we revised to report the first, like the 87 is the first 60, 90 is the first 20. And then the codes were also revised to kind of clarify that the comprehensive care plan is established, implemented, revised, or monitored. With the previous description, it was kind of, people were thinking that you had to, you know, do something to the care plan, where the intent really is to make sure that you're monitoring the care plan. So you might not have to change it, but you do need to review it and make sure it's being done from time to time. All right. So the surgery section, or the codes we kind of call the 1000 through the 69990. So here's just a breakdown of where the changes are within the areas. So there's not too many that are going along here. But the first two, we've got the 19324, which is your mammoplasty augmentation, is being deleted. And when when CPT was doing their review, they were kind of taking a look at, okay, do we have codes that are kind of obsolete? Do we have them that are redundant? And so they were taking a look at this code and said, okay, when you're doing an augmentation without the implant, you're really doing a graft of autologous fat. So they're going to delete the 19324, and then the suggested replacement codes are the 15771 or the 15772, which is your grafting of the autologous fat harvested by liposuction technique. And then with the 19366, the breast reconstruction, there is no direct replacement for the code. And so they just said to go ahead and use the appropriate breast reconstruction code that's already in existence, or use the unlisted procedure code. Now, there are a lot of revised codes. What they did was kind of made the wording more up to date. So in that first line we've got there with starting with the 11970, they really just replaced the word prosthesis with the word implant. And then other codes were revised to replace the word mammoplasty or mammary with the word breast. And then what's nice with the codes 19364, 19371, and 19380, they've had some clarifying instructions added to the base description, where then we've got the 19367, 68, 69, 70, and 71 were just kind of reworded for consistency. And then also we've got the list of codes there that were made parent codes in this description. All right, so here we've got kind of a list of how that kind of plays out. So your 11970, replacement of tissue expander with permanent implant, is going to be the new description rather than the replacement of tissue expanded with permanent prosthesis. So, you know, the 19318, it's a breast reduction rather than the reduction mammoplasty. So, and then with the 19330, where it used to just say removal of the mammary implant material, now it's clearer, stating it's the removal of a ruptured breast implant, and it includes all the implant contents like your saline or your silicone gel. So that's really nice. And then with the 19357, you can see where that's going to state, you know, tissue expander placement in breast reconstruction, including subsequent expansion or expansion. So some of that is really nice. And then you can see now with like the 19364, which is in the middle of the page there, that we've got the breast reconstruction with the semicolon, because it's now the child code under the parent, with a free flap, and then they give you the definitions of the flaps there. And then with the 19367, you've got it's, and the 19368 are specifically stated as being single pedicled, where the 19369 is now specific to bipedicled. All right. Now within the musculoskeletal guidelines, they have added some updates, particularly to give you some guidance regarding a loose or foreign body. Now, the arthroscopic removal of a loose or foreign body may be reported separately when the loose or foreign body is too large to be removed through the arthroscopic cannula that's being used for that procedure. And so, and that includes when the loose or foreign body can only be removed through an enlarged arthroscopic portal. So that one does not necessarily have to be a separate incision, but you may have to make your original opening larger to be able to remove the body. And it can also be when a separate incision is necessary. And then there are two code updates here, and the Cliff Notes version of the descriptor has now been expanded to the Shakespearean version, I guess you could say, but there's additional guidance stating that a limited is going to be one or two discrete structures, and they have included the different discrete structures for you. And then extensive is included 3 or more discrete structures. So they do have it separated out by whether you're working on the cartilage or the bone, such as your humeral cartilage or your humeral bone. And then also whether on the rotator cuff, whether you're working on the bursal side or the articular side as well. So that will be kind of nice. Now, in the respiratory section, there are 2 new codes, the repair of a nasal valve collapse with your lateral wall implants, and that's kind of a stiff implant that's, this can usually be done in an office setting, but it's like a stiff little implant that they can place in the kind of in the nostril area, and it keeps the nostrils open. And so then it eventually kind of just bioabsorbs into the body. Really kind of neat. Now the 32408 is a suggested replacement code for our deleted code we'll talk about next. And it's for a core needle biopsy, the lung or your mediastinum, so percutaneous, and it includes any imaging guidance when performed. And for most of the time, it is performed doing the with imaging. But what it is also doing is taking the 32405, your biopsy of your lung or mediastinum, and having and stating that this is a core needle biopsy for the 32408. Now, if you're doing a fine needle aspiration biopsy, then you should be using the fine needle aspiration biopsy codes. And it uses a much smaller needle and takes, they aspirate some of the stuff, and it's usually sent off for cytology, where the core needle biopsy procedure uses a much larger needle, takes tissue samples, and that's sent off to pathology. So if you do ever go take a look at the needles, it's, the fine needle aspiration biopsies are really very small. When you're taking a look at your core needle biopsy, that's almost like the size of something that you would use to inflate your bicycle pump, or a basketball. Sorry, I don't like needles, so that kind of scares me. All right, moving on to the cardiovascular section. We've got a new code here. We've got your transcatheter atrial septostomy, and this is for a congenital cardiac anomaly, and it is going to be replacing the deleted codes, the 92992 and the 92993, moving it from kind of that medicine section in the back up to the surgery section where it should be. And this is for taking a look, getting the blood flowing correctly in the baby's heart. So now I do have a note here that says a diagnostic cardiac catheterization is not typically performed with the 33741, so it may be coded separately when performed. All right, now we do have some new transcatheter intracardiac shunts to do a stent placement. And so this is really another kind of interesting one. And there is new guidance added to the shunting procedures. The 33745 does include the diagnostic cardiac catheterization, which is typically required. And it also is going to include your angioplasty. And then if multiple stents are reported, you can go ahead and use the 33746, but it pretty much includes the entire cast of what's going to be done. So it's really interesting to kind of read about this procedure, because these are usually used when the physician is inserting a stent into the baby's still beating heart. Well, and I put baby, it could be a little older. All right, so we've got some changes to the ventricular assist devices. And so here we've got the insertion of a ventricular assist device for the right heart. And then we also have a removal of the right heart ventricular device. And what this does now is it provides the opportunity to revise some of these codes so that you have specific codes for left heart and specific for right heart. And then now the 33993 is for left or right heart for the repositioning. So gives you the ability to be more specific and covers both sides of the heart. All right, and then for the digestive section, we have the 49220, which is a staging laparotomy for Hodgkin's disease. And so the guidance is to report the CPT codes for the specific procedures performed. So if you're doing a needle biopsy of the liver, report the existing code for the needle biopsy of the liver. So instead of bundling things in this instance, they're now telling you to unbundle. All right, there is a new code in the male genital section. There's the 55880, which is your ablation of malignant prostate tissue. And it may look familiar because it's very similar to the C9747. The C9747 is not being deactivated yet, so we might have to keep an eye out on that. And the AMA said, okay, well, this is ready for a new normal CPT code, but they did include the definition, the descriptor having malignant. All right, and then they have a new female genital section code. It's a computer-aided mapping of the cervix uteri during colposcopy, including the optical dynamic spectral imaging and algorithmic quantification of the acetyl whitening effect. And so this will always be performed when the colposcopy is done. And so what it does is it takes the images and just kind of overlays them over the top of each other, and it gives the physician the ability to see more accurately if there's any anomalies in there that might need to be addressed. All right, so we have two deleted codes, the 57112 for your vaginectomy, and then the 58293, which is your vag hysterectomy for the uterus greater than 250 grams with the colpourethrocystopex, but they did not delete the one that is for under 250 grams, so it's still there. So it could be that these just were not being reported, and if you are providing these services, then you would use the unlisted code. All right, so we've got some revisions in the nervous section, not a huge thing, just that the 64400 is now going to be the parent code to the codes that are revised. It was already the parent code to the codes in that section, so it's not a huge change, but you'll see that, that's why now we've got the little semicolons instead of the, commas and stuff. All right, so the 61870, your craniotomy for the implantation of neurostimular electrodes. The suggested replacement is the 61850, the twist drill or bore holes for implantation of the neurostimulator electrodes. Now, if you're not doing the twist drill or a burr hole, then use the unlisted CPT code. So, and you can see that there's other codes here that are deleted, but there's no suggested replacement. And we've got some new auditory section codes. So we've got the nasopharyngoscopy with the dilation of the eustachian tube. The 69705 is unilateral, 69706 is bilateral, so we don't have to worry about having to do the modifiers and and we won't have to worry about CMS disagreeing about the unilaterality, but ears are paired organs, so that should be okay. Anyway, so the 69605, your revision mastoidectomy has been deleted. There is no direct replacement. So take a look at your other revision codes there, the 69601 through the 69604, to see if those will work, or of course the unlisted procedure. All right, and we are moving along to the radiology section. There weren't a lot of changes here. Probably one of the most interesting ones is the 71271, your computed tomography thorax low dose for lung cancer screening without contrast materials. Now the G0297 that's in use is being deleted at the end of the year. And the 71271, I guess the AMA decided, hey, this one is good enough to go ahead and use for a real CPT code after how many years. Now the 76145, your medical physical dose evaluation, this is to be used when your physicist has to use a there may have been an event where the exposure was greater than, lower or higher than what your facility threshold is per your policies, and so an evaluation and report needs to be done. For example, if the exposure is like 10 gray, that's considered a sentinel event by the Joint Commission, and so there needs to be an investigation done and report. So you've got a way to report that now. All right, 76970 was has been deleted. The guidance says to use the ultrasound exam based on the site studied. So if you're doing just the bladder, report that code. If you're doing just the so this one would not be used. When they were doing the review, they found that for the most part it was being coded incorrectly. It was being reported with the vein stripping procedure, and I can't remember the word for that right now, but varicose veins, there we go. And it's included within the procedure, so it should not have been separately reported. And 78135, your red cell survivor study, is being deleted, and so they did suggest if you are doing the survival study, report the survival study. If not, go ahead and just report the unlisted code. And it could be that there just wasn't much usage of that code. All right, now we've got some revised codes. The CT of the thorax have been updated to include the word diagnostic, so you can differentiate it between the screening thorax, the screening CT that's new for that for the lung cancer screening. Excuse me. And then the 74425, the urography, the antegrade urography, is removing the names of the test from the descriptors, the description, so that you can go ahead and use it for whichever test you're using. And then for the ophthalmic ultrasound, there was some question whether it was only unilateral or whether it was bilateral. So they updated the description to say both. All right, and the pathology codes. There are 10 new drug assay codes, and they used to be reported with the 80299, so nicely the code will be more specific and available. And these are not for definitive drug testing. These are for therapeutic drug assays. And so it's looking for the known therapeutic level of a drug that could be over the counter, and how that is reacting, and it's also taken from either like blood, serum, or cerebrospinal fluid, where the most of your definitive drug testing is urine. So take a look at the guidelines, because they do kind of help try to point you to where the codes are going. All right, or where you need to go to pick the right code. All right, so here we get into the molecular pathology codes, and there are 16 new codes available, and these used to be reported in the Tier 2 codes, and now they're getting their own Tier 1 procedure codes. As the testing becomes more prevalent and there's a clinical need for a specific code for the test, then they're being moved from the Tier 2 to the Tier 1. So that's what a lot of this movement is. And so because these are new codes, there are updates to the Tier 1, the revisions to the Tier 1. So here we've got, I'm not even going to try to pronounce any of these because that's out of my wheelhouse. And so it is telling you the specific item that they are testing for. So, and here's some more. So you can go ahead and take a look at these when you get the slides back at your leisure. And this is this rounds out the last of the new MoPath codes. And so I did not include the entire description of the codes that were revised, because these are the ones that are pages and pages out of your CPT book. So you can see where the item was that now has their own code. It's being removed from that Tier 2 descriptor. All right, and then for the molecular multi-analyte assays, we've got some, I've got 2 slides that contain the 6 new MAAA codes. These are always kind of interesting as you read through some of these. And so the last of these, so. All right, and so there is one deleted MAAA code, the 81545, and there is no suggested replacement. So go ahead and report the specific tests performed, and we just included a few examples here. And it could be that, if the lab goes out of business that was the proprietary lab for this test, that the test may no longer become available. All right, and we've got a new couple of new chemistry codes, and so you'll see that the 82077 is alcohol, any specimen except urine and breath, and that it's an immunoassay. And then the 82681 is an estradiol free, because we have in the revised section now the estradiol total. So you can see that there's a difference now. There's codes for the free and for the total. All right, so we're getting back to the medicine section. And we do have a new immune globulin available, and this one is for rabies immune globulin, and this is solvent or detergent treated, and it's the only one that's solvent or detergent treated. There are some new codes in the ophthalmy section, and this is the 92229 imaging of a retina for detection of the monitoring of a disease. So this is really looking at the retina to see if there's any diabetic retinopathy going on. And it is a point of care service, and it is kind of artificial intelligence. So there's a machine that reads the retina, and then the code can be used by that reading physician or your other qualified healthcare provider, which is your nurse practitioner, a physician assistant. And so the updates then that are made to the ophthalmology codes here are kind of clarify this, and it's kind of using the same type of test. So here you've got the imaging of the retina with a remote clinical staff review or a remote physician review. So the 92229 is used when the physician reading the report is there in the same location. The 92227 and the 92228 can be used if the person doing the reading is not there. So if it could be that if you have a clinic in several clinics in different locations, and you have the machines available, the patient can have the scan done, and then the information goes to either the clinician or the physician to read, and they could be, back at on the main campus or in a different clinic to do the reading and provide a report. So it's really interesting. All right, so we've got some new otorhinolaryngology codes. So for the vestibular evoked myogenic potential testings, your VEMPs and your CVEMPs, and your OVEMPs. So what this does is it actually gives you full coverage for the vestibular evoked potential. So that's exciting for the ear, nose, and throat guys. All right. And for the auditory evoked potentials, the two codes on our next slide with the deleted codes are kind of non-specific. So here they've really broken it out and given 4 different new codes. So your 92650 is for a screening. And so the 92651 is for a hearing status determination, and then your threshold frequencies. And then the 92653 is for a neurodiagnostic exam. So they did go ahead and delete the 925, 85, and 86 and have you go ahead and take a look and report the service that is being provided. All right, and then we have a bunch of new cardiovascular monitoring codes. And so these are actually replacing some of the category 3 codes. And so these are kind of filling the gap for the existing code that allowed reporting after you have 16 days of, the minimum of 16 days of data. So what the physicians were saying was sometimes we need to monitor for less than that. So you've got a set of codes that are to report when you have more than 48 hours and up to 7 days for the continuous rhythm. And then this next set is for 7 days up to 15 days. And this is your continuous rhythm. All right. And then they have a new test for bronchospasm, and it's going to include your pre and post spirometry and your pulse ox. And this one is without your ECG or EKG. And so they have then updated code 94617 to be with the EKG. So you've got one with or without. And so here within the pulmonary code section, they have deleted quite a few codes. They're basically, a lot of these are obsolete and not being reported. Now your expired gas collection, the 94250, they did not have a suggested replacement, but those could include, and we've included some of those tests there. All right. So again, here's some more deleted codes. And then within the category 3 codes, these are usually put in place and monitored for about 5 years to determine whether they can graduate to be a real CPT code or whether they aren't used and then be deleted. So here we've got, an endovascular venous arterialization with the stent placement, includes ultrasound guidance and all of that fun stuff. We've got 2 new codes for a trabeculostomy, and what this does, the excimer laser is a cold laser therapy for treatment of glaucoma, and it just goes in and it's able to minimize the fibrosis of the tissue. And so we've got automated quantification of the coronary arthrosclerotic plaque. And so what this does is it takes a picture and is really close to providing the result. It provides results very close to what the physician would see if they were doing a catheterization, but it's non-invasive. And some more with the different types of guidance. So this is from CT angiography, and the other was ultrasound. All right, and so here we've got the percutaneous injection of an allogenic cellular or tissue-based product. And the other one was ultrasound guidance. Here's CT guidance. And then we've got your visible light hyperspectral imaging measurement. So they can take and shine a specific type of light on tissues, and it will light up and show how the patient's vascular access is, and double check things like diabetic foot ulcers, pressure wounds, and see how the tissue is. And then we've got a new code for the ultrasound ablation of nerves innervating the pulmonary arteries. And then we've got some CT of the breast, including your 3D rendering, and it has with, without, with, and without. And then you've got your unilateral codes here, and then this next page is for your bilateral codes. And then here is now a wireless skin sensor that can be used. So instead of having to open a patient up to check if there's a blockage of the CSF shunt, there's now a skin sensor that's able to do that. All right, so here we get into a lot of the deleted codes. And a lot of these, they don't have specific suggested replacement codes. So I'm not going to spend a lot of time here because a lot of these maybe were just not reported. And then when we get into the 0295T ranges, they do have suggested replacements. These were the ones that we covered back in the medicine section. And so I'll just kind of whip through these. But you do have the list here of your deleted codes, so you can kind of review those and see if you use them. And Dusty, I got done with my slides.
Perfect. Thanks, Ardith. We're actually just at time, so if you got to run, I totally understand it. Ardith, do you have like 5 minutes? We can answer a couple of these questions at least live.
Yes, we can.
Okay, we'll do that, and then we will send out. We'll do our best to answer all of them and send those out as a follow-up document as well. Let's get to a couple questions here. I'll start at the top. If documentation supports a lower level of code based on total time, but the MDM constitutes a higher level, the E&M level can still be assigned to whichever is more advantageous to the provider, correct?
Correct. Yes. You can use either time or medical decision-making. It's whatever is more advantageous. And at the CPT symposium, they did go through some clinical some examples, and they said, okay, even though they may have spent, 10 minutes, the medical decision-making and the exam actually supported a higher level of service.
Great. Next one here is, would you change a 99202 for an RN visit now that 99201 no longer is applicable?
No, because the nurse has to be working incidental to the physician's plan of care. And if you're using a new patient visit, the physician has not been able to establish the plan of care. And so that does not qualify as an incident to service.
Is CPT 99201 for PB only?
No, it is being deleted, and that would provider based only. So no, the 99201 is going away, and it's not able to be used any longer. And so that applies to physician practices as well as provider-based departments.
Great. Next one is, how often can you build a new code for complexity adjustment at every encounter when addressing the chronic conditions?
Right. There was no discussion of that, but it would be, it could be that every time the patient comes in, that you could bill that. So I'm really hoping Medicare comes out with some more information.
All right. How about G2211 has a status indicator equals N. Do you expect this to change? Will this code be applicable for the hospital TC services?
For the hospital side, it's a status indicator of N, which means it's going to be packaged into the payment for the primary service, which would be your office visit. So you can report it. You're just not going to get any separate reimbursement for it.
Right. Next question. Do the chronic care management codes apply to outpatient wound care patients?
It can. So it's just, all depending on whether, if you are going to bill for those or not. And it, there's some nasty wounds out there. It wouldn't surprise me if you couldn't use it. So.
Sure. All right, a couple more. Can you clarify Medicare wants G2212 with their timetable and AMA wants 99417 with their specific timetable, correct?
Correct. Yes. I'm sorry. It's a mess. And so depending on, so for Medicare, there's that extra 15 minutes that CMS is going to make you wait. And so there is that separate timetable when you're reporting the G2212. I'd have to go back and look, but yes. So anybody, somebody that's on one of the blues, you'll be able to use the 99417. But, anybody that's Medicare, they would need the G code, and then there's that gap in time. And the AMA did put quite a few tables in for the prolonged service reporting this year. So those are very helpful.
All right, I think we got time for two more, and then we'll get going for today. Can you explain again the 64400 code and what that change was on the slide you showed?
Oh, okay. All right. I can't remember what slide page that is. It's just it's more of a verbiage change than anything. And so it just kind of means that sorry, I had a lot of slides. Past it. All right. So what it does is it just really changes how the display is. And so there's this part. So you'll notice that for the most part, it's everything after the semicolon is going to change. See, and this one is for each additional level, lumbar sacral. So it's just kind of saying, hey, this is a parent code. So the 64400 is really just going to say the injection, anesthetic agent, and or steroid. And then everything after the semicolon is the part that's going to change, but the parent code stuff stays the same for all of them.
Okay, one more quick, and then we'll get going. Can the parent or guardian be considered an independent historian when assigning 99202 through 215 after 2021? If so,
Yes.
do you have any resources?
Yes, it's in the E&M guidelines.
Okay.
And there's a definition of who can be an independent historian. And yes, it does provide that information.
Okay, great. We will, again, we'll make sure all these are answered and documented, and everybody should be able to receive those or find those on our webinars page on our website as well. Again, you all got CEUs today. We'll email that information out along with where to find the recording and the PowerPoint from today's webinar as well. We do have a couple more webinars planned for the month around E&M and OPPS yet. And so if you're not registered for those, make sure to check those out. And there are more CEUs for those as well. Otherwise, Ardith, did I miss anything? Anything else you want to add?
No, I think we're good. Just remember, next Thursday, we've got our E&M longer version. next Thursday at 10 Central. No, 10 Pacific.
Noon Central. Yep.
Noon Central.
Perfect. Thank you all for joining so much, and hopefully we will talk to you next week.
Right.
Have a great day.
Bye. Thanks, everybody.